Welcome, everyone, to another episode of LifeSpark Live, The Complete Shift, where we take the time to have national conversations about senior health that no one is having. Together, let's get to the heart of the matter, to an ever-growing aging market, revealing the opportunity, mindset, and solutions for a much-needed complete shift in senior health. I'm Joel Tyson, a nurse, CEO, and the host of LifeSpark Live. I'm so excited to talk data, depth, and humanity with all of you. Let's get the conversation going. Hello, everyone out there. I am Joel Tyson, and I am excited today because we have an extraordinary guest in Ann Tumlinson. Ann is somebody that I've respected and watched over the years, and I can't wait to share her narrative with you today. So let's get this thing started. Ann.
Great. Thank you. I'm glad to be here.
All right. So I'm going to start off some questions here, Ann, for you. So in your blog, Daughterhood, and even in the Health Affairs article where you shared your personal experience with your parents, you saw firsthand how broken the system is, right?
Yeah.
Are we at a point, do you think, where our payment systems and designs are up to the task for caring for this aging population that we are talking about?
Yeah, no. No, definitely not. And, they're about, honestly, they're like 30, 40 years out of date. So the way we pay for healthcare, now it's changing. We're trying to change it, but still, for the most part, whether it's commercial employer-sponsored insurance or Medicare, we're paying for units of service. So we define a unit of service, and then it's delivered, and then we pay for it. So a hospitalization, a physician visit, SNF day, home health episode, all of those are units of service, and we're paying for these units of service, which are wholly and entirely disconnected from each other, and which incentivize crazy stuff.
Exactly. There's a lot of crazy out there, right?
Yeah.
You were going to say something. Go ahead, Ann.
Oh, just, I am on the board. So I serve on the board of a federally qualified health center. I also serve on the board of a physician group. And, in both cases, organizations that are very innovative and moving towards value-based care and trying to enter into risk-based contracts to align their own financial incentives with the kind of care they want to deliver. And it's incredibly hard. And they're still, they're sort of betwixt and between because they're so, innovative that they're practically having to kind of like what I'm sure you experience every single day. It feels like they're hacking their way through the current payment systems in order just to kind of get the finances to flow in a way that's consistent with good patient care.
Right.
And really, we sit and look at the financials and it's, how many encounters? We still have to pay attention to units of service because that's what pays the bills still.
Yeah, it's the old heads in beds and kind of volume versus value and a lot of these things that we've been watching for a long time, which are quite frankly pretty sad, right? When you make it that complicated, when it's really just kind of common sense, I would say. Let me kind of go, this is a little bit more heady and I'm just kind of throw this out there quick and then we can go into some more details. But, when you think about it at the kind of that morality level, I mean, where do you think we're failing seniors and family morally, like with this system?
There's just an unbelievable amount of suffering that's happening as a result of this disconnected, there are multiple failures. So there's the failure with the delivery of clinical medical care, particularly for individuals who have, sort of complex clinical profiles. So there's that's a failure.
Yep.
And the other failure is in there's no actual financing system for many of the things that people need. So they need housing, they need long-term services and supports, they need food, they need transportation,
right.
and none of that's funded really. So that's, and then the final thing is the failure of infrastructure. So we don't have any kind of system to help organize, anything. So across all of those domains. And as a result, and when I say suffering, what I mean is essentially that every single family is creating its own completely unique and separate system of care delivery by itself without any help, and managing it. So that is, if you think about that from a societal perspective, I guess here's Anne moving away from morality and into efficiency. I just like,
Sure.
because I'm super uncomfortable over their morality, but from an efficiency, it's like ridiculously inefficient.
Yes. Yes.
And so you would think the private sector would step in. Oh, there's an inefficiency. Here's an opportunity for our wonderful capitalist system to step in and fix it, but it can't.
Mm-hmm.
It really can't, it can to a certain extent, and we see wonderful innovators like you in this space doing doing great work, but it's not yet fully scaled, and it hasn't taken hold everywhere because you can only do so much private sector innovation in a space where there's so much government money that's kind of working at cross purposes. $700 billion a year is working at cross purposes,
Right.
for the most part. And I mean, this isn't, I shouldn't pick on Medicare and CMS too much. They are doing great work around the ACO model. Medicare Advantage program is growing, and it is a nice platform if you can make it work, for value-based payment to providers to do the kinds of things that you're doing. So it's not like there aren't ways in, but there's a lot of capital that's required. There's a lot of energy that's required. And it should be the default. We should be sort of like rushing to invest
Yeah.
as a public sector and a private sector, and we're not.
I like where you were going though with that, that suffering, right? There's so much suffering that goes on in the situation. And you obviously followed up with the point that everyone's, kind of an N of one, right? I mean, that everyone has to go resolve and recreate this ecosystem for their parents and for their loved ones. And what a sad state of affairs that is, quite frankly, right? That's just ridiculous. And when we talk about funding, and I know you talk about that a lot, and you talk about policy, and you talk about, kind of the things that you just stated, my belief, quite honestly, is there's enough money in the system, right? We're just spending it in all the wrong places. When you think of the amount of money that's being spent through the broken, fragmented quagmire of hypersegmentation, how do you kind of contemplate? How do you think about that? I mean, do you think there's enough money? I mean, is it spending more? It's not spending more money on seniors. It's spending it in the right places. And if you do believe that, then where are we getting it so wrong?
I'm going to have to do some math out loud in order for my brain to answer this question. But so if you take with the average rate of hospitalization, or the rate of hospitalizations in the sort of in that frail population defined in a particular way, and it's in the like 600 to 650 per 1,000. So it's a lot of people going to the hospital, and there's enormous variation around that number. That's how there's inefficiency, because there's some people who are going 10 times a month, and some people aren't going at all. All right, so that tells us that there's an opportunity there. And if you bring that down to 300, which is where it could easily be in a really well managed healthcare environment, there's think about so you're saving on the ER visit, you're saving on inpatient hospitalization, you're probably saving on the post-acute care. That money, the goal is to take that money out of that hyper segmented system, save it, and then repurpose it into a variety of different things that generated spit out the other side, a much more what we call in policy land person-centered, but just means, healthcare that's designed to address the needs of the people it's serving.
Wow.
So,
That's
but I think where I am a little skeptical about whether there's enough is when I start to think about the population that has what I call sort of catastrophic long-term care needs. So the individual with Alzheimer's disease that can't be managed in a traditional family setting, somebody who really needs that sliver of the population. So it's for everybody turning 65 today, 15% of us will need supports and services with 2+ activities of daily living for 5 years or more.
Mm-hmm. Yep.
So that 15% funding that day-to-day care provided by a direct care worker, either in a nursing home setting or at home, like that piece, I don't think we've funded. I don't think we have enough money in the system to also cover that. But I do think there's plenty of money to do kind of everything else. And then what I would like to see is a dedicated stream of funding for people who end up in those catastrophic situations to help fund the services needs, and that would be integrated in with everything else that we do. So,
Yep.
let's make the current thing a lot more efficient and high value and person centered. Then let's create a funding stream for that growing part of the population that's going to have those long-term service supports needs, and then let's put it all together.
Yeah, that's great. I really appreciate that commentary on that. I mean, I have a personal belief as well. I mean, I think there's, like you said, there is so much in there when you get into more of, we're talking a lot about the health care system, right? And we're talking about the polychronic, very sick populations with a lot of medical conditions, and we're talking about, rehospitalization rates per thousand and those types of things. But I just being in the space for so long and being a nurse myself, I've seen where when prevention is really kind of many times not really focused on in this, in this world, right? And when I see when I really look at this population and I'm working with them on a daily basis, there's a lot of folks that we don't measure avoidables, right? We don't measure the amount of money that's avoided. That's really, obviously a non-hospital event, right? And so the model and the market gets so enamored with, with acuity and sickness and disease and running metrics because it's easier to do. I get it, right? But the reality is a lot of seniors when they get into older adulthood and quite frankly when they get pretty frail and later in life, right? A lot of people sometimes they're not even educated to make that choice of, do I want to have a palliative approach or do I want to have a restorative approach? And I'm not talking about hospice, right? I mean, I'm talking about really even before that, as you know. So I guess I just, I don't know what your thoughts are on that, but I think we do a really, really poor job because we're so drunk on acute care that we forget that, boy, we could avoid a lot of acute care altogether if we have a different mindset on life and how we live in our later years. So I don't know, any comments on that or thoughts on that?
Oh yeah. So, because what I was saying earlier, I'm glad you said this, because I was sort of, a lot of times when I talk about aging, I tend to mix longitudinal activities with point in time activities. So when I was said, 15% of us are going to need at some point so that we should be able to get that 15% down to 5.
Right.
So because we should be able to extend life and increase the span of time that we feel good and have lives that are full of meaning and purpose.
That's right.
And so but what's happened is we've expanded life and kind of all of our gains in longevity have been gains in bad longevity, like sick time, what we call morbidity, spells of morbidity. So do we have enough? If we were able to do that, so because I was talking about like a point in time, if we get our hospitalization rate down for the people who are sick today, there's a lot of money. Yes. If we were able to reduce, say, like the incidence and prevalence of Alzheimer's disease, which we know is possible through lifestyle changes and prevention and avoiding hospital delirium. I mean, there's a lot of things we can do going all through the whole lifespan, quite honestly.
Right.
With respect to brain health, like we could get that 15% down quite a bit. And that becomes an affordable insurance product, right?
Right. Oh, sure.
Like we can fund,
Right.
and then we can help just that 5% who have just really bad genetics or what,
Right.
so there's so much that we can do on a like lifetime basis that we're not doing. And that's where our financing system is a completely inadequate.
Right.
We don't, everything's an annual, except for the Medicaid program, which is at risk for long spells, but they don't, it's a,
Yeah, they're at
I
risk,
don't think
but
about
they're
that.
at risk, but they don't transfer that risk. They transfer it on bit size at a year at a time, as you know, like through our Medicare Advantage contracts. And
Exactly.
so
And I think
I'm with you.
yeah.
There's a risk, and that risk is really us, right? Because we are the
Yes, that's right.
payers. So it's not
That's
the
right.
government, making some, grandiose kind of give out, right? So I mean, it's really
That's right.
our dollars. But that's really interesting. And again, I just wanted to test your kind of push your thinking, or at least get your thinking on sort of that whole idea, because until we get, I know you're a very big believer in, people, Bill Thomas and Richard Leiter, purpose and passion and identity and things like that. And a lot of these don't even come up in the conversation in acute care reform or healthcare reform. A lot of these things aren't even, people like to say SDOHs now, and, they get excited, but as you know, it's still very early, and there's not a lot of energy pushed. And I mean, I'm really looking for, I think like you, I'm a big believer, like I want to be a big thinker in like true redesign for serving and solving big problems like housing, like food deserts, like, helping people that can't help themselves. So let me ask you this, since we're on kind of policy a little bit, let me just change it a little bit, is, when you think about even that carve out group that you were talking about, it could be many carve-out groups. In this case, you used, dementia or Alzheimer's or whatever, right? But people that have catastrophic disease, long-term disease states, right, that are complicated. Where do you see the policy? I mean, who's responsible for that? I mean, where do you think, who should pay for that, and how should it be paid for in your mind? If you could be the czar of all things, right?
Yeah. Well, here's what I will tell you. It's a little controversial what I'm going to say, but there's only one way to do it. There's only one. If what we're talking about here is ensuring or creating an insurable, there's an insurable risk. And that insurable risk is that you will be among the 15% who need hands-on daily care from another human being to do at least 2 or more of those basic life activities for at least 5 years. Mm-hmm. So 15%, that's insurable risk. The only way that you can insure insurable risk is if everybody is in the risk pool. So long-term care insurance, private long-term care insurance has failed largely because it's a private product and there are just not enough people in they're trying to underwrite that risk on an individual basis, which is nuts. Yeah. So, and it completely didn't work. And so we have to come together as a society and share risk, which we don't like to do. So it's a very, very challenging thing to solve politically, because we need a social, this isn't Medicaid. This is, somebody be like, oh, we have Medicaid. Medicaid is not that. Unless you consider, insurance against that 5+ years as being a Medicaid reimbursed nursing home bed, in which case, okay, fine. Mm-hmm. But you also have to bankrupt yourself to get there. So if we want a system that doesn't require people to bankrupt themselves in order to end up in a Medicaid reimbursed nursing home bed, then we're going to all have to share in the risk of facing that possibility in our lives. That's how the math works. That's not me being, a left-wing, socialist. Sure. That's just me explaining actuarial principles.
Yeah.
And so that's what we have to do.
Yeah, I think that's a great, and again, I've read some of your work, and I know I've sort of heard you talk a little about that. So I wanted to have it come out a little bit, because it kind of comes to, I mean, doesn't it kind of go then to, because long-term care insurance, I was a big believer in the 90s. I thought it was going to happen, right? Really big. I thought this is going to solve a lot of problems, right? And you know why? And states were doing it, and I mean, they were pressing, and then it kind of died. It died on the vine, right? And then obviously everybody that did do it got hammered because they didn't do good. It was the actuarial studies were bad. And anyway, that whole industry. But I guess I go back to then, I mean, at a macro level, at a government level, at a society level, we kind of do that, I mean, with Medicare and
Mhm.
Medicaid, like duals, and we're started doing that. Would you, and where I'm going with this is, would you advocate, I mean, if you could, again, I'm just asking you just hypothetical, because I just love your thinking.
You're gonna make me say
You know where I'm
okay,
going, right?
I'm gonna go there.
All right, go ahead. Go ahead. I don't even, I mean, I could ask you, but you probably know that question.
No. Go ahead. Ask the question.
So would you say, like, would you be kind of, would you promote then a one payer system, and kind of, you know, collapse these things around, this full insurable population?
No, so what I would do is create a social insurance program specifically for the catastrophic events and allow for, as we like to do in America, for the private sector to play a role in managing it.
Mm-hmm.
Or, you know, filling in the gaps and things like that. So I would not attempt is like appealing as it is to me and through a conceptual basis to like roll up, you know, Medicare and some new long-term care program and everything into one big, I mean, theoretically that could work, but it would be so disruptive. And so I sort of feel like if there's one thing that we could do is to just what we're essentially doing is talking about kind of creating a funding stream that we then allow organizations like LifeSpark essentially to help, you know, manage on behalf of the individual. So think about, it's a little bit like if you're familiar with PACE, you know, it'd be like if you LifeSpark and, you know, had, you know, a population under your management, and in addition to having their healthcare dollars in those instances where that person had, you know, that really, really high level of disability, you also had these dollars from the federal government, and those dollars were made available because it's all part of a financing scheme, you know, that forces everybody to pay for it.
Right.
So, you know, like the ACA.
Yeah.
So that would enable like you know, a lot of scale. You know, so because what I hear, so for example, in the, just to get really wonky with, is like, you know, when you look at like these, you know, C-SNPs and IE-SNPs, these like special Medicare Advantage plans that take care of these special populations, the reason they sometimes struggle outside of the senior living environment is because, or try to do what PACE does, but they're missing, PACE has the long-term care dollars and these SNPs don't. Right. So if imagine creating, if I were queen for the day,
there you go.
Imagine I would just create basically PACE-like programs for everybody. Yeah. Like everybody who was at that level of need would have access to something that essentially builds on that model, instead of it just be dual eligibles who have nursing home levels of need.
Yeah, no, I'm with you 100%. And I'll take this another direction quick. But before I do, in the 90s, I started my first company called Advo Life, and it was completely based on the PACE architecture. I went to the Family Caregiver Alliance. I went to Unlock. I did a bunch of work because I was so enamored. And at the same time, long-term care insurance was kind of trying to happen. So that was the thesis, to serve all seniors, right? Because my intent has always been to serve all seniors, not just some seniors, not just the rich ones, not just the poor ones, but really all seniors, right? I mean, with a thoughtful, holistic, longitudinal experience, right? And so anyway, just FYI, I just want to let you know, like I've been a long believer, and I still am. And unfortunately, as you know, again, a lot of these things get a little bit butchered because of the adoption curve, where people don't want to give up their volume business. They don't want to give up their heads in beds. They don't want to give up their big, expensive architectures to redesign. And so with that said, I mean, how do you see, and kind of go in a different direction a little bit, how do you see like practicality, your advice to providers? And again, I know there's such a wide swath when I say that, providers, but when you think of thought leaders that are trying to really redesign the experience for seniors, you know, what's your best advice? I mean, where can these folks really grab on? I mean, where can they grab on and actually make a mark or move the momentum, right? Build the movement. Like, what are you seeing there where people are building the movement? Where is it going? Where you see groups coming together in meaningful ways? You know, as you know, within risk contracts with, global risk, et cetera. What would you recommend, or what are you seeing that would be interesting for the folks out there?
The hard truth here is that you really have, if you as a provider organization want, to kind of reinvent what it is that you do on a daily basis around clinical processes and care delivery, with a couple of maybe small exceptions, which I could talk about, you really have to find a way to be at risk for actuarial risk. Not even, you can do a lot with a per member per month, which is kind of operational risk, but actuarial risk, you're on the hook for the total costs of care for a population that is otherwise hard to manage. And there are lots of pathways to put that together at scale, enough scale, but it's really hard to do otherwise. Okay, so having said that,
well, I love that you said that, because I'm shining inside, and because I believe that if you don't, I believe exactly what you just said. To not take full global, you cannot truly play in both one foot in each canoe and all the BS that people do.
Hard.
Yeah, it is.
And we've seen the organizations that have really pushed in that direction do quite well. In terms of their valuations, in terms of their, sort of financial performance. Now, there are kind of two little exceptions I might make to that. One is partnerships. So, if my business depended on me working only with organizations that wanted to take total cost of care risk, we wouldn't have have much of a business. So
yeah, but you'd feel really good inside, though.
Yeah.
You'd be morally aligned with everything.
Well, ironically or paradoxically or something, it feels like most of the organizations that are prepared to do that also seem to also have all of the skill set. They don't really need consultants. They're just sort of like, we get it. We're ready. We're going.
Yeah, fair enough.
But it's organizations that aren't prepared to do it. They come to us because they're like, we can't do that. We're not prepared. Our board, blah, blah, blah. So then what we do is we say, all right, well, let's figure out how you can partner, partner as much as possible to bring with organizations that are taking total cost of care risk, so that you can bring the benefits of that to the people that you serve. So I'll just pick on like a home health agency, like a big home health company, if you woke up one morning, you're like, as you should, this home health benefit is really a bummer to deliver because it doesn't do much. We want to do something more, but we don't want to take on risk. We don't want to add primary care capabilities, all the things that you have to do to be really competent at managing actuarial risk. So we're going to go find a partner, and we're going to partner and work out sort of terms that are mutually favorable in terms of volume, shared savings, et cetera, and performance and things like that. And I think you can get close, and I think you can definitely help the people, but there's still a lot of work to do in those partnerships. There's a lot of you have to redo a lot of your, sort of care pathways and things like that.
Yeah, I think that's great advice. And I really do. I think that's what I talk about as well. A lot of times is partnerships are hard, right? And they really are, especially in these types of ecosystems where you're trying to create, really, they are hard. But what's great about them is they are centering in the sense of we actually are talking about when you do that and you do that in a partnership, you can really focus always on the client, right? You always focus, a lot of people don't, right? They focus on their economics, or they focus on their payment
Yep.
structure, they focus on whatever, disease. They basically focus on everything but the client. But when you do, it's really serving. And I think really it is the next wave of success for all types of organizations, profit, nonprofit, I don't care. But the people that hold the trust with these folks, I know, again, back to daughterhood and around the navigation, around going it alone and all the things that you've learned in your own life, is that, the people that are able to be those groups that can build the trust with those families and those daughters and those clients, those are the people that are going to win, right? Because they really understand that longitudinal, that lifelong perspective, and they understand the truth in really about what we call aging magnificently, right? I mean, there's a way to do that. That, to your point, I remember way back in my early days, I think it was Carbonell, she said something like, we've figured out how to extend life, but not how to improve living, or something, to that end, right? So and you were saying that before, and I think that by doing it, by not having that navigation, right, or that navigation system, it's almost impossible. So I really like where you were going with that, and I think that's where partnerships, as well as individual organizations and groups, when they do get on the side of true accountability around the total risk, you start to look at the client differently, right? Because you look at their you look at their psychosocial factors, you look at their purpose, and you look at their food in the fridge, and you care about those things. Not that people are inhumane that are in healthcare delivery aren't, but it's just a different mindset. So anyway, I really like that, and I appreciate that. So I think we've covered a lot of ground. I would just ask, is there anything that we're missing that's one of the key things that you really care about that the audience should know? Any of the key areas that you really like to focus on, either through ATI or through your daughterhood?
I thank you. Your questions were terrific, and I feel like I got to tell everybody exactly what I think about some really big things on the ATI side. I think what I would say on the family caregiver piece of this is that it's just, as if you're, it's really hard to communicate just how overwhelming the process is of beginning to have to take care of and manage the day-to-day care, both medical and otherwise, for somebody who can't do it by themselves, for another adult, whether it's your parent or your spouse or your aunt or even an adult child. It's all consuming. It's really and like really hard. Family systems are really hard to navigate. So I'm sure providers like, yeah, tell me about it. But I think we are lacking in imagination in thinking through how the world could be a much sort of easier and more humane place to live, this country in particular. But we've got a pretty short period of time. We've got 3 to 4 years to really kind of figure this out and make the investments before we have sort of this, and I hate the word silver tsunami. I'm not going to use it because it sounds like it's not a natural disaster, right? But the prevalence of these needs is going to skyrocket with the rapid growth in the overage 80 population. And then it's just going to be one more, I think, sort of stress and tension point on a society that already has a lot of stress and tension points in it too. So I think, let's just all keep working really hard, doing the best we can to improve it.
Well, and that's why we're doing this, right, Ann, is because, these are the conversations that people have to have, and they have to know the truth, right? I think a lot of people either, we have ageism, we have, avoidance, we have fear of death, we have fear of mortality, morbidity. I mean, a lot of these things cause a lot of problems. And, one of the things that we've learned over the many years, again, I've been doing this through 2 companies, we call them life managers, but they're really that quarterback person, because until that trust, back to that trust, and then somebody that really knows how to navigate, those two components, I mean, yes, physicians are important. Yes, subspecialties are important. Yes, hospitals are important. But really, what's most important is the understanding and the true life plan that has to happen at each individual's level, right? So, and then obviously navigating that. So I really, I think you're exactly right on, and we do need to move. I know you talked about the silver tsunami, but there's a pig in the python or the age wave, and we talk. There's a lot of talk about all these things. In fact, we've been talking about PACE for 20 years, as you know, right?
I know.
We've been talking about a lot of these ideas, and unfortunately, the market holds us back with really perverse economics, perverse incentives, right? I mean, when we reward people for sickness, that's a really sad situation, right? And that's what we do. People don't like to say it that way, but I do, because I want to be provocative, because I want to call it out and say, look, when you're sick, the more volume, the more money a system makes, right? But when you're healthy, they make nothing, so they have no incentive. And I've been in rooms with CFOs of health systems that said, look, we love what you're doing, but we just really need heads in beds. I almost want to come unglued, right? And so I think this kind of dialogue, which I thank you for today, is really important and rich, and we can't be afraid. There's no reason to be afraid. We need to march into this, and truly it's our opportunity to do good in the world. So I know you're one that does great good in the world, and I want to thank you for today, and thank you for the dialogue, and we need to keep talking, Ann. So thanks for that, and thanks for all your wisdom and your hard work around being that true advocate out there.
Thanks for this show. Thanks for doing this.